at this point to welcome our speaker. Before I do that, I just want to tell us a little about her. She's Professor Bola Adekoya, a decorated ophthalmologist and glaucoma specialist at the Lagos State University College of Medicine and Teaching Hospital, LASUCOM/LASUT. Our work focuses on the epidemiology, genetics, medical, and surgical treatment of glaucoma. Through her extensive research and advocacy, she has contributed to glaucoma care policies in sub-Saharan Africa, improving treatment accessibility, and patient outcomes. She's the current head of Department of Ophthalmology, LASUCOM/LASUT, and she's also the Secretary, Faculty of Ophthalmology, National Postgraduate Medical College of Nigeria. And then she's married with and blessed with beautiful children. With Jesus joy in our hearts, let us make welcome Professor Bola Adekoya as she takes the stage for the next section, which is the presentation and why we are here. Thank you very much, Ma. Ma, you have the floor.
Thank you so much, Dr. Theophilus. Hopefully I can quite audible everybody. So I thank CMDA National, CMDA LASUT for the invitation to share a little bit about glaucoma among health professionals. We usually get this type of invitation to share information about glaucoma in the community, in various workplaces, but not directly to health practitioners as a whole like this. So this is a rare opportunity, and I appreciate CMDA LASUT for the invitation. So without further ado, let's go straight into the topic, which is the role of healthcare practitioners. That means our role, not just as an ophthalmologist. We know as healthcare practitioner, we have several subspecialties in medicine. So, and we all have a role to play when it comes to preventing glaucoma blindness in terms of awareness, detection, and appropriate intervention. So this is going to be our content, what we are going to be discussing today, understanding glaucoma, and then looking at the roles of what role that we can play as physicians, as general physicians, as specialty physicians, as surgeons, community physicians, and so on, in preventing glaucoma blindness. So you agree with me that blindness is not something that is something that concerns all. So when a person has some form of visual impairment, not to even talk about blindness in a particular family, it affects everybody. It doesn't only affect that person that is blind or has visual impairment. One way or the other, everybody will be affected. So we can all come together in preventing glaucoma blindness. It's not just an ophthalmologist alone. Yes, ophthalmologists do majority of the work, but every physician, every health worker can definitely play a role in reducing and eliminating glaucoma blindness. So we first of all talk about what glaucoma is. So from our early medical days, if you are not ophthalmologist or we are not doing research in ophthalmology, from early medical school days, I'm sure we've had lectures on one or two lectures on glaucoma, and maybe we saw one or two patients with glaucoma when we did a short rotation in ophthalmology. So glaucoma can be generally defined as a group of progressive eye diseases that is characterized by optic nerve damage and visual field loss. A group, definitely, because it's not just a single disease entity, because there are several diseases that constitute this entity called glaucoma. And two things that all of them have in common is the optic nerve damage and visual field loss. So when the optic nerve is affected, definitely there will be resultant visual field affectation. Most of these patients that have glaucoma, they usually associated with a high intraocular pressure. And that used to be one of the key definitions of glaucoma in times past. But it's now been found that even patients that have what we call statistically normal intraocular pressure within the statistically normal range, some of them may still develop glaucoma. So that is why the emphasis is no longer on the high intraocular pressure as a definition of glaucoma, even though intraocular pressure is a very, very important aspect of the risk factors for glaucoma, but it's no longer included as part of the definition. And if glaucoma is not treated, it definitely will lead to an irreversible loss of vision. And it's in fact the number one cause of irreversible blindness worldwide. And it's often referred to as a silent thief of sight because many patients are completely unaware that that they have glaucoma until it is quite advanced. And that is one of the key challenges that we have when it comes to glaucoma. And that is where a collaborative effort of all stakeholders, all healthcare workers, including other subspecialties in medicine and surgery, can really, really go a long way in reducing this burden of blindness. So a lot of patients they don't know that they have glaucoma as high as 50%. And even in resource-limited environments like ours, the rate is much, much, much higher of people that are going about with glaucoma in their eyes and they are completely unaware. And that is because at the early stages, glaucoma does not cause any symptoms at all. No pain, no redness, no itching, nothing. So by the time a patient is coming for the first time and noticing that something is wrong with the eye, oh, it seems I'm not seeing quite well. A lot of damage has already been done. Like I mentioned, it's irreversible. At least for now, it's irreversible because of the fact that it is a nerve that is affected. Okay, so we have a global prevalence of 3.5%. However, this prevalence is much, 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 much higher among patients of African populations. So, and even in us as Africans, this disease that is called glaucoma also appears at an earlier age. It's also more aggressive and also progresses much, much more rapidly. So it's as if we've gotten the trifecta of the disease affectation in African populations. So a lot of patients are affected globally. In fact, by year 2020, it's been estimated that we'll have more than 110 million people affected by glaucoma globally, with quite a significant amount of these people being blind, not blind in one eye, but blind in both eyes. So that's a very high disease burden all over the world. In Nigeria, it is the second commonest cause of blindness in Nigeria after cataract. But we know cataract is completely reversible. It's completely curable. If somebody has cataract, we operate them. They are saying they are regaining their vision back 90 to 100% of the time. But the same is not for glaucoma. So it's like double jeopardy. There's blindness, and then the blindness is irreversible when it comes to glaucoma. And in Nigeria, the prevalence is particularly higher among the Igbo ethnic group. This is from the Nigerian blindness survey that was done a couple of years ago. A lot of factors have been postulated to be responsible for this. Of course, the exact cause is still not yet known, even though a lot of genetic studies are currently ongoing. But of course, we have to consider genetic factors. Some dietary factors we also consider, and even pro-inflammatory factors we also are also in consideration as being responsible for the higher prevalence of glaucoma in Igbo ethnic group. Of course, socioeconomic factors and access to care, they also affect whether this patient will be able to access care when they need it. Okay, one thing is for somebody to be detected and discovered to have glaucoma. Another thing is for them to have access to care, to be able to afford their medication, to be able to afford their surgical plan. So, but the patient is able to afford their care, even when we detect glaucoma early, the outcome may be unfavorable in this category of patients. And majority of our patients, unfortunately, fall within this category. Poor socioeconomic factors affecting the eventual outcome, even when glaucoma is detected early. So when we put all these things together, the high burden of the disease, high burden of visual impairment, poor socioeconomic factors, of course, the resultant poor quality of life, and associated mortality. Because it's been found that once a patient becomes blind, the risk of mortality increases significantly because there are so many things, they become dependent on others and they are not able to perform majority of the activities of daily living. They have anxiety, they have depression, and associated psychosocial affectations. So we can see that therefore this glaucoma is a disease of significant public health importance. And that's why all hands must be on deck to ensure that we eliminate glaucoma blindness. So just a brief introduction about what we mean glaucoma types. There's different types of glaucoma. We have more than 50 types of glaucoma, but just briefly to let us know that at least some of the common ones that we have within in our community. The primary glaucomas are there. The secondary glaucomas are there. The primary glaucoma we have those that we regard as open angle. There are those that we regard as closed angle. However, the primary open angle glaucoma, we shorten it as POAG, is the commonest all over the world. It's also the commonest in Nigeria. It's also the commonest among African populations. So, in fact, almost 70% of glaucomas are primary open angle glaucomas. It's similar to the systemic hypertension being commonest and maybe has no known cause. So there's no direct either ocular or systemic association when we are talking about this primary open angle glaucoma. Of course, we have other types of glaucoma. Secondary glaucomas can be caused by things such as ocular injury, ocular inflammation, systemic diseases, even steroid use. If somebody uses chronic steroid for a long-term basis, it can also be a cause of secondary glaucoma. With respect to intraocular pressure, and I mentioned earlier that intraocular pressure is no longer a key definition, part of the key definition of glaucoma, because some patients have their intraocular pressure within the statistically normal range, and still they have glaucoma. So regard this type of patients as having normal tension glaucoma. And there are some patients that have intraocular pressures above the statistically normal range, which is usually between 10 and 21 millimeters of mercury. This category of patients are regarded as having ocular hypertension. Of course, at the end of the day, we still have to individualize patients' treatment according to what they present with. And if even normal tension glaucoma, they will still need to be treated. Of course, glaucoma can also present in an acute fashion. Okay, so it's not everywhere, it's not all the time that they present in a chronic fashion. Of course, majority of patients present in a chronic manner. This is something that has been there for a long time, chronic, insidious, gradual, progressive. But sometimes we have a category of glaucoma called acute angle closure glaucoma that can present suddenly. It can present with severe pain. This kind of patient can present in the medical emergency. They will have vomiting, they will have severe dizziness, they can even collapse from the severe pain and distress that can occur from the acute angle closure glaucoma. Of course, there will be severe pain, severe reduction in the vision. We also have a whole group of glaucoma occurring in children and young adults. That's another different disease entity on its own. So we can see now that for glaucoma, is no respecter of person. It can affect any age. It can affect any socioeconomic group. It can affect any form of the patient that's had any form of ocular injury or insult before. So even when somebody has high pressure, low pressure, glaucoma can also occur. So these are just briefly some of the different types of glaucoma that we have. So what are the risk factors for glaucoma? When we talk about any particular disease, we want to understand what are the risk factors, what are the factors that are associated with developing this disease. Some of these factors are not just risk factors for development of glaucoma, they are also risk factors for development, for progression and even for blindness. A lot of this, to focus, number one among this is an elevated intraocular pressure. So it's been documented all over the world that there's absolutely no doubt that a high intraocular pressure that is greater than the statistically normal range can cause glaucoma. And like I mentioned, even patients with normal tension glaucoma, some of them may still develop, they may also develop glaucomatous damage. So it's not just about having normal intraocular pressure. We also want to look at the eye. We want to look at the optic nerve and see whether, even with these so-called normal pressures, has there been any damage? So it's very, very important that we check intraocular pressure. And this checking intraocular pressure is not something that is out of reach of every physician, especially primary physicians, who have a portable device that they can use to measure intraocular pressure. Even the most rudimentary instrument, we call it short tonometer, that people can be used even in the rural area. It doesn't need any instrument, it doesn't need any battery, it doesn't need any other device other than a very small the device to just place on the eye and measure the intraocular pressure to a reasonable extent. So it's not just in an eye clinic that this can be found. In our primary eye centers, this is something that it can be instituted, can be placed there. And of course, when officers and staff are trained on how to use it, measuring intraocular pressure will not be a difficult or a big deal. They can be measured, and patients that may have high intraocular pressure can be detected early. Because when intraocular pressure is high, especially when it is high on a chronic basis, most patients will not know. We'll see patients presenting to our clinic with pressures of 50. Imagine for somebody that's supposed to have blood pressure between 10 to 21 presenting with 50, presenting with a 16 intraocular pressure. So somebody coming to medical emergency with a blood pressure that is 200, 250. So you can see how alarmed we'll be. And this patient will be walking around completely as if nothing is going on, normal in quotes. So when we see those type of intraocular pressure, of course, we are also very, very quick to ensure that we institute treatments to lower the intraocular pressure immediately. Another very important factor is family history of glaucoma. So glaucoma is a genetic disease. So it's been proven that glaucoma is a genetic disease. In fact, from all the chromosomes in the body, from chromosome 1 to chromosome 22, and then to the sex chromosome, it's only the Y chromosome. I'm sure the guys will be happy now. It's only the Y chromosome that does not have a glaucoma, a gene that is associated with glaucoma, whether directly or indirectly. So from chromosome 1, chromosome 2, chromosome up to the X chromosomes, every single one of those has a gene. In fact, some of them even have 2 or 3 or even 4 that are associated with glaucoma, whether directly or indirectly. So glaucoma, the genetics definitely plays a very, very important role. And when we have first-degree relatives, a parent, a sibling, it increases that risk about 4 times, especially in patients with primary open angle glaucoma. So it's a genetic disease, and that is quite obvious. But one of the things that we do when we see a patient coming to the clinic and they come with their relative, they come with, wow, you could ask how you related to this person. Are you their relative? Are you their father? Are you their son? We use that opportunity to screen their eyes. That's what we call opportunity screening. Another very important risk factor is increasing age. Okay, as we grow older, a lot of non-communicable diseases are somehow inevitable. Of course, depending on our lifestyle, depending on all the other factors, we can keep all these communicable diseases at bay. But increasing the age is a risk factor for glaucoma. Of course, we can also have glaucoma even in younger people, even people that are younger than 40 years of age. So it's not as if we don't see it in children. We say we have congenital glaucoma, we have infantile glaucoma. Ethnicity and race is also a very, very important factor. Of course, that's also that's also related to with the family history, with the genetics of glaucoma. And primary open angle glaucoma has been found to be much more prevalent in us as Africans, whereas angle closure tends to be commoner among the Asian population. So other risk factors include, as I mentioned earlier, long-term steroid use, not just eye drops, even systemic steroids. There are patients that are on systemic steroids for whatever reason, whether for systemic inflammation, for systemic autoimmune conditions that they have to be on systemic steroid for a long time. We need to send them for glaucoma screening. Even inhalers, that some asthmatic patients may be that have to be on inhalers. I don't know what the current treatment modalities is now, whether some patients may need to be on steroid inhalers for a long time. When somebody is asked to be on that, and there are some patients that we call steroid responders. So that even if they've been on, even if they are not on long-term steroid, they tend to respond to steroid use, and that can lead them to developing a high intraocular pressure and subsequent glaucoma. So if a patient has to be on steroid for longer than 2 weeks, it's good to establish a baseline for their ocular parameters, including intraocular pressure, and then monitor them subsequently after that. Intraocular trauma, injury can lead to secondary glaucomas, refractive errors, thin cornea, and also some certain medical conditions, hypertension, diabetes. They are all related, they are all risk factors that has been associated with glaucoma. So what are the clinical features? What do we see in these patients that have glaucoma? For the primary open angle glaucoma, which is the commonest type of glaucoma, as I mentioned, completely asymptomatic. In fact, it's been termed the silent thief of sight. And that is quite poignant in the fact that it is exactly that. It's a silent thief of sight. By the time we see most of our patients, unfortunately, in majority of our clinics in Nigeria, one eye is already gone and the other eye is not far behind. That is a very sad situation in all instances. And some of us, because a lot of these patients, they start with a peripheral loss of their vision. And because it's the periphery that's usually affected initially, most patients will not need it, will not notice it until it's very late, until they have what we call a tunnel vision, which is just very, very narrow central vision that is now preserved. So that is why it is a silent thief of sight. It is a very, very devastating eye condition. But all hope is not lost. Even in advanced cases, patients that present with advanced disease, I've seen patients that have been or have detected on advanced disease, and they've been stable and well controlled for 10, 20, even 30 years. They have not lost their vision. So it's not as if all hope is lost. So if it's not treated on time, the effects can be quite devastating. It can lead to complete blindness if not treated. And as I mentioned earlier, acute angle closure glaucoma can present as an ocular emergency. It can even present like a medical emergency that the patient will really be medically distressed, and they will need to be treated accordingly. All right. So what are the available treatment options that are available for some of our glaucoma patients? Before we treat any patient with glaucoma, health education is so important. We mentioned that it is irreversible. We mentioned that it's a lifelong disease. We mentioned that it is genetic based. We mentioned so many risk factors associated with this condition. But a very, very important part of it is the fact that it is irreversible. And if patients and even their relatives, not only the patient, their relatives also, if they don't understand those fundamental principles of what the disease is, what are the available treatment options, the need for continuous lifelong management. If they don't understand that those basic fundamentals, it is very, very difficult for them to comply with therapy, whether medical, whether surgical. It's very, very difficult for them to comply. And of course, they tend to go from doctor to doctor to doctor to doctor, looking for cure, looking for a reversal of their vision, which unfortunately may not happen. So health education is so crucial. And of course, a lot of our institutions now, we have educators, we have counselors that even after we have spoken with a particular patient, if we still think this patient still need more counseling, we refer them to the counselor to be able to talk to them in detail. And of course, when the patients come, we ask them. That's why sometimes they say, "Oh, talk to my brother, talk to my son." And I say, "Okay, yes, I'm willing to talk to whoever you want me to talk to, but give me a minute, maybe come back, maybe after the clinic, and then we'll have a longer chat with whoever." Or I say, "Okay, give my number to so person, let the person call me, and then we'll be able to have a longer chat." So it's very, very important that we explain in detail for this to the patient. And this is why we're also, as health practitioners, as physicians, we can also help in ensuring that we communicate some of these basic fundamental issues to the patients, in ensuring that they understand what the disease is all about. So for glaucoma, the basic treatment is to reduce intraocular pressure by whatever means necessary. And we have several ways in which you can do that. We have medical therapy, we have laser therapy, we have what we call MIGS. This is minimally invasive glaucoma surgery. And then we have the glaucoma, the conventional surgical methods. In the past, and we're talking about 20, 30 odd years in the past, this was the landmark when we are talking about the glaucoma treatment options. Medications, we had just like two. We have beta blockers, and then we have pilocarpine. Lasers, of course, maybe one or two centers in Nigeria had lasers. Definitely not more than that. There was no minimally invasive glaucoma surgery, and surgery for glaucoma was just what we call trabeculectomy, just one. But now we have a whole lot of options. There's been a really, really big explosion in terms of the type of medications. Even we have prostaglandin analogs. We now have different types of prostaglandin analogs. We have miotics. We have even newer agents that have not been completely new medication, new formula, not as if it's a derivative of a particular formula that we've been using before. So we now have a lot of options available when we want to treat glaucoma now. Of course, there are barriers to each of these treatment options: affordability, availability, even training, the surgical and the equipment infrastructure that is needed may not be available. But things are generally getting much, much better. A lot of these things are now available in many centers. So we have a lot of options at our disposal. Okay, and even at the primary care level, a lot of medications patients can have their medications follow up. Patients can receive their medications from their local pharmacy. They don't have to travel all the way from wherever they are coming from to a teaching hospital to have their medications refilled. So these are some of the things that can improve glaucoma management overall and prevent glaucoma blindness. So we talked about understanding glaucoma and from introduction to the treatments that are generally available now. So what is our own role as physician when it comes to minimizing glaucoma blindness? So the first thing is awareness. Awareness. We have mentioned earlier that less than 50% of people that have glaucoma are aware that they have it. And of course, if somebody doesn't know that they have something, there's no way that they can act on it. Okay, the Bible says, "My people are destroyed for lack of knowledge." If you don't know something, there's no way they can act on it. So physicians, especially those in the primary care, are very, very important. And all of us also, whether we are in surgical care, we are in primary care, we are in medicine, pediatrics, we are all very, very important in educating our patients about glaucoma and its risk factors and the importance of regular eye examinations. Okay, the same way we have collaborative efforts in managing our patient. If I see somebody that I think may have, see a pediatric patient that I think may need pediatric input, I refer immediately to see a pediatrician. If I see somebody that I think we need a medical input, I refer immediately to a medical practitioner. So the same thing, if somebody is diabetic, somebody has a family history of glaucoma, that's why we should ask about all these all these histories in our patients. If we see that this patient has some of these risk factors that we have discussed, we should send them to an ophthalmologist. So every primary care visit, every patient encounter is an opportunity for us to educate our patients on glaucoma. There's nothing saying we can't have a silent chat in a clinic. As you are consulting, ask the patient is reading and see, it seems I cannot read that. And then you will detect that something may be going on. It may even be something else apart from glaucoma, but general eye checks may be very, very important when it comes to those patients, especially those that are high risk groups, those that have those risk factors. And when we put all those risk factors together, we find out that almost all of us are at risk. We're talking about race, we're talking about family history, we're talking about age, we're talking about high intraocular pressure. At the end of the day, all of us are at risk at one point or the other. That means every opportunity that we see our patients, we should use it to educate about glaucoma, about eye care. And of course, causally about glaucoma being a silent thief of sight, regular eye care is very important. Of course, we can also use those opportunities to dispel some of the myths and misbeliefs that some of these patients may have. They say, you contact glaucoma by touching somebody. If I put the eye drops for 1 month, my glaucoma will go. If I put wiper in my eye, it will completely wipe out the glaucoma. And all sorts of things that some of these patients may believe in that may be detrimental to their eye health, to their even eye care. That will be an opportunity for us to counsel these patients effectively. Of course, for our church health programs, okay? Well, this is one such example is we want to incorporate eye and glaucoma talks in our wellness programs. We are with any time that we have the opportunity to organize any health screening in our churches. It's always an opportunity to include eye health as part of what we want to screen for. When we also organize community medical outreaches, we want to also include to ensure that we include eye health, we include glaucoma screening in this as part of these programs. So talks, information pamphlets, encouraging screenings, and all that. All of that we do, even as for our churches, for the community, we go a long way in ensuring that we reduce glaucoma blindness. Of course, the world is a global village now. A majority of our churches, our groups, even CMDA webinar, we have a digital platform from Facebook, on Twitter. So when we post these informations regularly here and there, it will get to those that are actually need it, and they may be able to take action on time before they develop irreversible blindness. And of course, the church is big on advocacy. Okay, so advocacy for glaucoma patients, advocacy in terms of ensuring that we improve the awareness and ensuring that the glaucoma care is affordable and available, because that's a major barrier when it comes to patients accessing care. They are not able to afford. We detected the glaucoma. Yes, we told them that they have glaucoma and this is the stage. This is exactly what is happening. But if a patient is unable to afford their drugs, it's not useful. So advocacy as a church, as a group, as a medical group can go a long way in ensuring that we have adequate care, and these patients are able to access care when they need it. Of course, we usually celebrate what we call World Glaucoma Week. That's usually every second week in March. So that's a whole week, and to celebrate, to mark glaucoma. That is how important it is. We usually have World Hypertension Day, World this day, World that day. But glaucoma is such an important public health problem that the whole week has been earmarked by WHO to mark that day because of this issue of awareness, because of this issue of irreversible blindness. That's how important it is. So we must also, as physicians, see what we can do to reduce this avoidable blindness. And even as a physician group, we can sponsor medical outreaches, whether individually, collectively, to among at-risk populations, which, like I mentioned, is almost everybody in the African population. So these are some of the things that we can do when it comes to raising awareness. Early detection and, of course, prompt referral for treatment goes without saying. Once you're able to raise the awareness, a lot of people will come forward either to us as ophthalmologists or even to their general practitioners. They may even come to physicians, they may come to surgeons who have high conditions, and then will refer appropriately. So we'll ensure that routine eye checks are done for all, especially as risk individuals. And like I mentioned, it's not out of place for us to have, as physicians, as even surgeons, as community physicians, family physicians, to have our vision charts right in our offices, right in the community, to have a direct ophthalmoscope to be able to examine the patient's fundus and to be able to do basic intraocular measurements. So these are not complicated things that we cannot do in our clinics. And of course, by the time we do that, we'll be able to have more impact, and of course, we'll be able to maybe generate more revenue for our practice. So it's not out of place to be able to do all this for our patients, and that will have a longer lasting impact in being able to, even if it's just for that one patient that we're able to pick early that has a high intraocular pressure of 50, 60, and we're able to refer on time and prevent blindness in that particular patient, it may be well worth it. And of course, that is referred to ophthalmologists when glaucoma is suspected in any of our patients. Effective follow-up and compliance is also a very it's a very important aspect of how we can contribute as physicians to ensure that our patients remain compliant and they use their drugs when they are supposed to, because sometimes it can be quite tiring, either from they just say, I forgot to use my drugs, or they cannot afford those drugs. So the importance of medication compliance, when we see those patients, even when they come for their routine medical checkups, we can use the opportunity to reinforce compliance. Of course, we can also use the opportunity to monitor for systemic side effects of this glaucoma medication, because sometimes these eye drops, as small as it is, it's just one tiny eye drop in the eye, they can have some significant systemic side effects, like beta blockers, for example, can cause significant bradycardia in some patients that may be susceptible to that. And most of the time, it is the physician that may detect it, not even the ophthalmologist that may detect it, even though we tell the patient, if you notice this, please come back. But the bustle and bustle of the clinic may not even remember to ask the patient, do you have a reduction in your pulse? It is when they have gone to their physician who has to do most of those medical tests and investigation that those things are detected. So definitely that's a very, very important aspect of our work as physicians and even as community workers. Also for the patients, for effective follow-up and compliance, monitoring systemic conditions, the hypertension that may worsen the glaucoma, and of course collaborate with ophthalmologists for ensure continuity of care. And very, very importantly, which we don't do enough of, is emotional and spiritual support for some of these patients. This diagnosis of some of these chronic medical conditions, especially something as serious as glaucoma, that can cause irreversible blindness, can cause serious anxiety, and can be quite distressing for a lot of our patients. So empathy, encouragement, even praying with some of our patients, if necessary, can really, really go a long way in ensuring that we boost their emotional strength and they give them some form of support to ensure that they continue in the journey. Because yes, it's a lifelong treatment that they need to be, so that they won't get weary. Because that happens a lot. A lot of patients will use their drugs maybe 1, 2, 3 months, and they say, I was expecting that my vision will be better now. I'm expecting that I'll be cured, and then they stop. Not necessarily because they want to stop, or maybe that they cannot even afford their drugs, but because someone say, I don't see the point. I've been using this eye drug and I'm not seeing any change in my eye. So all those supports and collaboration, counseling, as we can go a long way for us as physicians to support these patients in that. So, and of course, lastly, but definitely not the least, physician heal thyself, as we see in Luke 4:23, that we should also prioritize our own general and high health. We'll be surprised that even among ophthalmologists, there are a lot of us that do not even check our own eyes regularly. Okay, so not just ophthalmologists or physicians, we should also check our eyes regularly. Check for glaucoma, check for also all the other chronic eye conditions that may be a potential cause of reduction in our vision. Of course, if it's something that is preventable, that is curable, like cataract, maybe you can leave that to whenever one has time to get around to it. But glaucoma cannot wait, and that needs to be sorted out. So even if it's our regular maybe yearly or every 2 years checkups. We should include glaucoma screening. We should include eye screening. So we need to avoid burnout and serve and ensure that we take care of ourselves, take care of our own eye health, even while we are taking care of other people. So by doing that, we are also leading by example. Okay, we are ensuring that our personal commitment to preventing health, to ensure that we inspire others, we inspire our patients to be able to do what we are preaching. Okay, so not if we are preaching something and we ourselves are not doing it, that is like double standard. Okay, so we must model the lifestyle and the health practices that we advocate for our patients. So, in conclusion, we've heard that glaucoma is a silent thief of sight, and that there are several risk factors that are associated with it. The chief of it is that everybody is at risk. Okay, but we can limit glaucoma blindness as physicians through adequate awareness, early detection, and referral, and of course, compassionate care as we follow up, as we support, and as we counsel our patients appropriately. And definitely, with doing that, we can be instruments of both physical and spiritual vision in our practice. And I pray that God will give us the grace and the equipment to be able to do this effectively. Thank you very much for your attention.
Thank you very much, Ma, for such an educative and timely presentation. We are very grateful. So quickly, we'll want to encourage participants that for as many of us that have questions, comments, please, you can put in the chat box for smoothness sake and for easy presentation and all. So let's just put in the chat box. But if you still want to talk, probably you can still indicate by a raise of hand. We have a couple of questions, Ma, and some comments on the chat box, which I will just read. So I will read everything, then
Okay.
probably you will respond to the questions after. So I'll start. The first we have here is, okay, first question is, thank you for the great presentation. Are there any diets that can prevent glaucoma? Are there any diets that can prevent glaucoma? Then the next comment is excellent, interesting, and educative presentation. Well done. Then the next is this is a great and insightful presentation, Ma. Please, beyond genetic and racial factors, please, what are the other modifiable risk factors for glaucoma which we could look out for? And then how do you slow the disease when detected? How do you slow the disease when detected? Then
Okay.
thanks for the presentation. Well done, Ma. Another comment. So another comment is thanks so much, Prof. Thank you so much for the presentation. So many thanks are in the chat box. Then, okay, another one. Thank you, Ma, for the enlightening presentation. Please, how do you handle bradycardia as a systemic side effect of glaucoma treatment? How do you handle bradycardia as a systemic side effect of glaucoma treatment? Next is excellent presentation. Then another question, how often should one check our eye pressure? How often should one check our eye pressure? Then, thank you for your presentation. What is the current prevalence of secondary glaucoma and what are the options for screening? What is the current prevalence of secondary glaucoma and what are the options for screening? Great presentation. Well done, Prof. I think that's all. Okay, then can glaucoma affect only an eye or one eye more than the other? Come again. And glaucoma affect
Maybe
only.
we should start. We should start
Taking the questions.
answering the
Okay, all right.
questions
Okay,
from the from, and then we can go along as there are more questions are posted.
coming in.
So
All
the
right, no
first
problem.
one I see here is about diet and glaucoma. So yes, there are several studies that have been done about diet and glaucoma. A majority of those studies are not conclusive, but it's generally advised that diets that are rich in antioxidants are good, not just for the, of course, not just for the eyes, even for the entire body. So we advise patients green leafy vegetables, diets that are very, very rich in antioxidants. So it's not as if there's a direct cause with association with glaucoma, but they've been found to be helpful in glaucoma management in general. Other modifiable risk factors for glaucoma. Well, apart from intraocular pressure happens to be the only modifiable risk factor for glaucoma that we can actually treat. Of course, dietary, like I mentioned, is not something that, of course, smoking. There's also been some association with smoking. Of course, somebody that is smoking can stop smoking, that improve their diet, a little bit of exercise, improve their exercise. But as I mentioned, there is the association between all those other possible modifiable risk factors are not strong. But definitely a patient will not, it will not be unbeneficial to a patient to engage in all that, other modifiable risk factors. Bradycardia as a systemic graft defect. Of course, when somebody develops bradycardia, the first thing we do is to discontinue the topical beta blocker. Sometimes, if we don't have any alternative or the patient actually needs those the beta blocker, we may substitute with a non-selective beta blocker. But the first thing that we usually do is, of course, is to discontinue and to refer the patient for a physician assessment as soon as possible. So that's the first thing that we do. We usually manage in conjunction with the physician. If they have to do some other investigations, adjust the medication. Fortunately, now we have many options for glaucoma management. So if something is causing significant side effects, we can substitute with something else. How often should we check our pressures? Of course, it depends on whether that person is a glaucoma patient, that person is not a glaucoma patient, or that person is a glaucoma suspect. For a glaucoma patient, that would also depend on what is the severity of their glaucoma. If it's somebody that has severe glaucoma, of course, at every clinic visit, we advise, of course, we check their pressures. And if the patient, for one reason or the other, is unable to make their clinic visits, we say, well, if you're able to go and check your pressures, maybe every 6 weeks or every 2 weeks, that's okay. Just for them to have a record that things are going on well. But if somebody is not a glaucoma patient and they are just doing all the general screening and all is well, maybe yearly, maybe once every 2 years, that is fine. And if somebody is a glaucoma suspect and we are not quite sure whether they have glaucoma or not, usually every 6 months to every year is also enough. Prevalence of secondary glaucoma. Unfortunately, there are several types of secondary glaucomas, from ocular trauma, from ocular inflammation to systemic diseases associated with glaucoma. So except we are talking about a particular types of secondary glaucoma, it's the prevalence is not quite quite difficult to estimate, but it definitely will be lower than what we have for primary open angle glaucoma. Can glaucoma affect only eye on one eye or more than the other? Okay, so glaucoma is usually a bilateral condition, even though one eye may be more severe than the other. So it usually affects the two eyes. This is a primary condition. In fact, when somebody has glaucoma that is just in one eye, then we are thinking more of a secondary glaucoma rather than a primary glaucoma. So primary glaucomas is usually bilateral, even though one eye may be more affected than the other. Role of nutrition, I think we have mentioned that. Tools that can be used as accurate basis for screening for glaucoma. Okay, so because as difficult as glaucoma may be when it comes to diagnosis, the tools are also not that difficult. Yes, there are we have simple tools. We also have some other very advanced machines that may be needed for glaucoma screening. But now, even now, we're having more portable devices. So definitely something to measure the visual acuity. That's a portable Snellen chart. That's readily available. We have a plastic Snellen chart that we can that is mobile that we can carry around. We have mobile tonometers now that we can use to measure the intraocular pressure. We have called the thermoscope that can be used to measure to assess the fundus. And even visual field. We now have portable perimeters now that we can use to assess the visual field, even in the field. So those tools are now much available and portable as opposed to what we have before. So those simple tools are readily available. Best approach to identify children with glaucoma. Unfortunately, because of the low prevalence of glaucoma when in children, of course, it would be good to have a national guideline when it comes to screening newborns for genetic conditions in general, the eye being part of that general screening. So I think that should be the way to go. So when a child is newly born, you screen them, examine them from head to toe. The hair, the eyes, all other organs are examined. So, but most of the time, when a child, if a child develops congenital glaucoma and we can see it at birth, most of the time the pediatrician or the parents will bring those children in soon after delivery. But if the child does not have those features ab initio at delivery, maybe it develops within a few months after birth, then it will have to be the parents that will have to bring that child in. So that's I think a general screening for babies when they are born, including eye screening, is the way to go. So that when a child now has the congenital glaucoma, they can be detected much early. Okay, so glaucoma suspect patient with borderline over several years of regular, there's any need to be worried. I won't say there's no need to be worried. So if there's a glaucoma, somebody is a glaucoma suspect, but you must ensure that all the necessary investigations and all the necessary assessment has been done to ensure that, yes, and then you must monitor that progression to comparing all those tests and assessing whether there is any change in those parameters. If there is no change, that means the patient may not have glaucoma. But it's also very important to rule out other things that may mimic glaucoma. Part of a very important aspect of that, we've seen patients with pituitary adenoma being treated for glaucoma for a long time. So that's top of the list that could mimic somebody that may have glaucoma and is not glaucoma. In fact, we see patients that have been treated for many years, and what they actually had was a brain tumor. So all necessary investigations and assessments should have been done. So once that is been done and the patient is stable and not progressing, I don't see any need to be worried. But everything that's supposed to have been done should have been done. Now that no microbiome, what other screening method is there? How can it be detected early? So it's not just, that's why glaucoma, the emphasis is no longer on intraocular pressure, because it's found out that some patients with normal intraocular pressure can also have glaucoma. And that is because there are other findings and other parameters that we use in diagnosing glaucoma. It's not just about the intraocular pressure. So the optic disc parameters are there, the visual field parameters are there. And even other investigations that we call OCD, OCT, which is like a scan of the retinal nerve fiber layer. So all that put together will help us to determine whether this patient really has glaucoma, whether this patient is a glaucoma suspect, or whether this patient does not have glaucoma. We can even sometimes the patient may actually need to have MRI done. As I mentioned earlier, there can be other things that can mimic presentation of glaucoma, and top of the list is a pituitary adenoma that we also need to ensure that somebody doesn't have. So, and even if somebody has normal tension glaucoma, the treatment is still to lower the intraocular pressure. Okay, so that's the modalities at which that will be done. That will be determined by the glaucoma specialist, but we still also need to lower the intraocular pressure. Trauma is a risk factor. What will be the precautions to take post-trauma to prevent development of glaucoma? All right, so if somebody has sustained any injuries to the eye, like either blunt ocular injury or even a penetrating ocular injury, of course, of course, prevention is always better. Because if the injury has already occurred, early presentation is very, very important so that if the patient develops intraocular pressure, or the patient develops intraocular inflammation, that will be adequately managed and monitored so that it doesn't lead to glaucoma. Because glaucoma is not something that develops overnight. Even when somebody has complications from ocular injury, it must be something that's developed from that and then gradually not treated. It leads to a persistently high intraocular pressure, and then that now leads to glaucoma. So early presentation, adequate treatment and follow-up will definitely impact and ensure that there is no development of glaucoma, even with somebody that's had intraocular pressure. Okay, some substitute beta blocker that can be used for xalatan. Okay, so xalatan is not a beta blocker. Xalatan is a prostaglandin analog. So we have a beta blocker that is not cardioselective is the one that is cardioselective is betaxolol. Okay, the one that is not selective is timolol. Okay, so we usually use that, and unfortunately, their intraocular pressure lowering effect is not as great as the latanoprost. So latanoprost is quite good. It's actually top of the chain when it comes to glaucoma treatment and glaucoma intraocular pressure reduction in glaucoma patients. So the substitute is betaxolol. Beta is a cardioselective beta blocker, but like I mentioned, even with that, some patients may still develop symptoms to it. So we have so many other, we have alpha adrenergic agonists, we have myotics, we have carbonic anhydrase inhibitors, we have rho kinase inhibitors, newer agents are now available. And of course, apart from medical therapy, we also have several laser therapies are now available. We also have several minimally invasive glaucoma surgeries also now available. And then finally, we also have several surgical modalities also now available. So the landscape is quite much improved for glaucoma treatment options compared to what it was before. Thank you. I don't know, hope I've covered all the questions.
Yes, Ma, you have, Ma. Thank you very much. I join my voice with others in the comment section
Thank you.
to show our appreciation and to say a very big thank you for this privilege to learn and for doing an excellent job.